Good evening, friends. We warmly welcome to the weekly postgraduate surgical clinics. Today we have two eminent national faculty. One is Professor Guru Shantappa, the head of the Department of General Surgery at KIMS Hubli. And we have Professor Nishikant Puja, again Professor of the Department of Surgery at Al Amin Medical College, Vijaypura. Both are from Karnataka today. And we have our own senior faculty, Srinivasan sir, Karnakaran sir. We have Rajiv Sakai sir, and few others are expected to join. So Shilpa ma'am is also expected to join. So we will have the arterial disease case first. And as once that gets completed, then we move to the obstructive jaundice. Today's case is going to be presented by Dr. Chaudhary. Chaudhary is from KM GS Medical College, kindly contributed by Professor Shilpa Rao ma'am. And I think Ashish has presented already some time back also. And the other case is going to be presented by a duo, Saket and his colleague. So there will be dual presenters from BJ Medical College. These students are kindly contributed by Professor Pankaj Modi. Thank you very much. And I'm sure Guru Shantappa sir and Nishikant sir already have been in our forum. So the student will be allowed to run through the history without stopping. We will stop there and you can revisit every slides and ask questions. The same way during the clinical thing. So we have about 45 minutes to 1 hour for the first one. And then by 9 o'clock, we move to the second case. That is the plan. Good luck to both the students. Can we have Ashish to start his presentation? Good luck to you, Dr. Ashish.
Yes, sir. Good evening. Just a second, sir. Just sharing my video, my slides.
Ashish sir, you are unwell, sir. Maybe you can have some water, sir. Sorry.
Sorry.
You please go ahead. Sir was coughing. That's why. Ashish, you are good to go, ma. Good luck to you.
Thank you, sir.
Make it full screen, Ashish.
Yes, sir. Is it visible, sir?
Perfect, ma. Good luck.
Good evening to one and all present for this session. I would like to thank Kanaval sir for this opportunity. Today, I would like to present a case on peripheral vascular disease. My patient is a 56-year-old lady, resident of Ahmednagar, homemaker by occupation, came with complaints of pain in bilateral lower limbs since 1 year, blackish discoloration of bilateral toes since 2 months, and wound over dorsum of foot since 1 month. Patient was asymptomatic 1 year back when she started experiencing pain in both lower limbs, initially on walking for 1 to 1.5 kilometers. Intermittent, the pain was intermittent cramp-like, and which patient was able to walk with difficulty, which slowly progressed to severe pain, compelling severe pain enough to compel her to take rest for 5 to 10 minutes to settle the pain. Gradually, it progressed on to pain even in resting state. Since the last 3 months, patient has severe continuous pain, which interferes with her sleep and not associated on medication, not relieved on medications, and partially relieved by hanging legs down by the side of the bed. Patient complains of blackish discoloration of toes of both lower limbs since 2 months, starting from the great toe, gradually progressive with involvement of the other toes. No complaints of cyclical color change with tingling numbness in the foot on exposure to cold. Also complaints of wound over dorsum of left foot since 1 month, painless, non-progressive, non-discharging. There is no complaints of trauma prior to blackening, no complaints of swelling, fever, or foul-smelling discharge from the foot. There is no complaint of chest pain, episodes of blackout, giddiness, syncopal attack, stroke, abdominal pain post meals. Patient is a known tobacco chewer since 30 to 35 years, consuming 1 pouch per day. No complaints, no history of alcohol consumption or smoking. Known hypertensive since 2 years, controlled on medications. No other comorbidities or COVID exposure in the past, and has been vaccinated with 2 doses of COVID-19 vaccine. No complaints of pain, swelling, or discoloration along the course of the superficial veins, and there is no complaints of pain in the buttocks and thigh region. Patient consumes a mixed diet and complains of sleeplessness in the night due to pain associated with daytime sleepiness, unable to carry out day-to-day activities. Bowel bladder habits are normal. Patient past history of open appendicectomy done 25 years back and tubal ligation done 20 years back. Currently, patient is menopausal and family history is insignificant. So, sir, summarizing the summarizing the case, patient is a 56-year-old lady, chronic tobacco chewer, known hypertensive, complains of pain in bilateral lower limb since 1 year with blackish discoloration
Put the history slides.
of bilateral
Put
toes.
the history slides.
First slide.
Yes.
Ashish, yeah, put
Yes, sir.
those history slides. Yeah. Just I wanted to confirm, you have made slides of the etiological history and complication history. Under those headings, you have mentioned some points.
Yes, sir.
Yeah, next slide. Yeah, this is history of next slide. Next slide. So is that is required or it is being taught like this? History of etiology, history of complications, or everything comes under history of present illness?
Sir, like it for the ease of remembering the sequence of the findings we are the history we asked, so we divide the history into history of etiology, history of complications, and
Just I wanted to know for information, is it being taught in your institute like this, or you have made yourself like these slides?
no, sir, it is taught like this.
Okay, okay, fine. Anyway, everything should be covered under history of present illness. That's what the clinical examination is on history taking. Fine.
Ashish.
This is very unusual. Ashish, this is very unusual.
Ashish.
Yes, sir.
All these points are covered under the heading of negative history.
So sorry,
No,
sorry,
somebody. All these
understand.
points are covered under heading of negative history.
Obstructive jaundice.
Okay.
There's some disturbance. Kindly mute, sir. Kanagil sir. Rajiv sir was asking something.
Right. Ashish, this kind of
Yes,
history
sir.
is very unusual. You have to make sure that it's all under one heading, and that is history of present illness, right? It's not followed anywhere in the world, right? So I think it's better if you just follow the usual pattern rather than coming up with some new stuff. Okay.
Ashish.
Okay, sir.
Sorry. Let's go back to your first slide. What do you think you're dealing with?
Hello.
Pain since 1 year, discoloration 2 months, and wound 1 month.
Sir,
Ashish, are you there?
here. Yes, sir. Yes, sir. Sir, I think on the basis of the complaints of the patient, because of the duration of the symptoms, it is a chronic vascular insufficiency.
Ashish, hang on. We didn't ask you why. We asked you, what do you think it is? Don't tell me why. We'll ask you why later on. Okay?
Yes, sir.
So tell us, what do you think you're dealing with?
Sir, it's a chronic vascular insufficiency leading to
Probably due to?
symptoms in the lower limb.
Probably due to?
Yes, sir.
Is it
Probably
arterial or
due to-
venous? That's it.
Uh,
You said vascular insufficiency. So what is that system
Probably due
involved?
to
What is
atherosclerosis,
the meaning
sir.
of vascular insufficiency, Ashish? What
Yes,
is the
sir.
meaning of
Wants to know
vascular
what-
insufficiency? Ashish, I am
So sorry, I
audible.
couldn't hear it.
Ashish, I am audible.
Yes, sir.
What is meaning of vascular insufficiency?
Sir, when the supply couldn't match the demand of the
There are two terminologies:
tissue.
arterial insufficiency and venous insufficiency.
Yes, sir. So vascular
What is-
insufficiency includes both arterial and venous,
Okay.
whereas venous.
Hello.
Ashish, you're muted.
Hello.
Ashish?
Ashish.
I think we lost him.
You unmute yourself.
Yes, sir.
Yeah, now. Okay.
Ashish.
So you think it's both arterial and venous, is it? Ashish?
Sir,
Yeah.
no, sir. In this case, I would think it is mostly arterial.
Okay.
No, mostly a bit
It's arterial.
likely. You tell us what it is.
Just
It's a
explain why it
chronic
is
arterial insufficiency.
Why?
Yeah, so
Justify your point.
Sir, because there is a blackish discoloration seen in the on history. The patient gives history of blackish discoloration, which is due
Okay.
to the arterial insufficiency, and also there's a wound which is present in the foot. And
Ashish, hang on.
One more
Ashish,
point.
Yes,
just
sir.
a minute. Give us the most important point first. Intermittent claudication,
That is most
rest
important
pain,
rather than
blackening
sir.
can be because of many reasons.
Yes, sir.
Wound can be because of many reasons. Give us the most important points first. What is the
So,
most important point in peripheral vascular disease? What is the most important history?
sir, the intermittent claudication of the patient. On walking, patient experiences pain.
Progressing to
Which-
rest pain, progressing to pain relief by hanging down the foot.
Yes, sir.
There are so many things. So name them one by one.
Sir, the history of intermittent cramp-like pain, which progresses, which initially is on walking a little. The patient has walks with difficulty, but after some time, the patient is able to walk with difficulty and has to take rest after some time. So basically, the history of intermittent cramp-like pain, and which decreases on.
Ashish.
Yes, sir.
Just give us the point. Don't beat around the bush. Just say intermittent claudication with rest pain,
Ashish.
with pain relief
Yes,
on
sir.
hanging the foot. Just go. Don't talk like an MBBS. Talk like a surgeon. Go on.
Yes, sir.
Just give us don't give the reasons for it. Just give us intermittent claudication, progressing to rest pain, with blackening of foot, relief of pain on hanging foot, history of smoking, history of hypertension. Go on. Go on.
Ashish, you did not mention about patient can able to walk after taking the rest, whether the distance regarding claudication distance. Directly.
Sir, no, I had mentioned that initially patient
What you
was
mentioned here?
having a pain for intermittent cramp-like pain and used to walk with difficulty.
And severe pain enough to compel the patient to take the rest for 5 to 10 minutes. You have not mentioned that patient can able to walk the same distance after taking rest before progress of the pain to the rest pain. You have to mention, na? Because
Yes,
this is in a sequence.
Yes, sir.
Whether claudication distance remains same or it is decreasing, that is more significant. You have not
Yes,
mentioned
sir.
here.
Yes, sir.
So progressively there is decrease in the claudication distance, and now at present patient is having pain at the rest.
Yes, sir.
What is claudication?
Sir, claudication is the cramp-like pain which is due to the insufficiency of the blood vessel, arterial supply to the muscles, which causes cramp-like pain.
Okay. What is claudication distance?
Claudication distance is the distance which the patient can walk without having pain.
No. Claudication distance is distance at which patient experiences the pain, and after taking rest, patient can able to walk the same distance. This is called as claudication distance.
Yes, sir.
And in history, which is significant, there is a progressive decrease in the claudication distance.
Yes, sir.
You're able to hear me?
Yes, sir.
Okay. Your patient is female.
Yes, sir.
Is it right?
Yes, sir.
Okay. And you have given at history level impression that it is an arterial disease, probably.
Yes, sir.
Okay. Is it an acute ischemia or a chronic ischemia you are suspecting at history level?
Sir, chronic ischemia.
Chronic ischemia. Which diseases are more common in females? Is it an arterial disease or a venous disease?
Sir, venous diseases are more common in females.
Yeah. I say this is a venous disease causing all of this. You just let me know at history level, what are the points against, or maybe one point, which is against for a venous disease in female, because your patient is female, where venous diseases are more common.
Sir, I couldn't understand what you said. Can you repeat, sir?
At history level, what is that which is against a venous disease?
Okay. Sir, in venous disease, the patient would be having a dull aching pain.
Don't tell me theory of venous disease. I want in your case, what is that point against a venous disease?
Sir, in my case, there is intermittent claudication, and the pain increases when the pain decreases when the patient
we understood claudication, presence
position.
of claudication pain, we understood. What is that point against a venous disease?
The pain decreases when the patient puts the legs down by the side of the bed.
Okay, in venous disease, what should happen?
It will increase, sir.
Very good. 1 point. Like that. Any other points to say that it is not a venous disorder?
Sir, in this case, the patient is having blackish discoloration of the toes.
Will it not happen in a venous disease? If it happens, what is the difference between these two?
Sir, in venous disorder, the blackish discoloration would be associated with wet changes like the edema and
very good. Swollen limb. What I expected was swollen limb. In this case, there is no history of swelling of the limbs.
Yes, sir.
Is it not? There is no history. And even if there is a blackish discoloration, it will be a ill-defined. What is that called in venous disorder causing blackish discoloration of the limb?
Sir, it would be wet gangrenous changes.
It is not called wet gangrene in a venous disease. It will have a ill-defined blackening and it will have a swollen limb. Cerulear,
Yes, sir.
and it will be painful. Cerulear dolens. It will have a
Cerulear
swollen limb,
dolens.
painful, and ill-defined darkening. Ill-defined. All these points are against venous disease.
Yes, sir.
Okay, you said it is a chronic ischemia. You are thinking in terms of at history level. I say it is a embolic phenomena causing blackish discoloration of the toes. How will you disprove at history level?
Sir, acute embolus will have short history like this. In my patient, it has a long history of 1 year. So it's a chronic history.
Oh, very good. Any other points like this?
And mostly the acute thrombosis would be from acute embolus will be from a thrombus in the body. So there would be other symptoms accompanying this symptoms such as blurring of vision or cardiac
Not necessarily.
chest
Not
pain.
necessarily. Okay, emboli
And, sir,
involving multiple toes in both of it, less likely.
less likely.
Emboli will involve, if there is an embolus to upper limb or the lower limb, which is the toe at a greatest risk to have a gangrene, if it is an embolus?
Sir, the grade 2.
Yeah, great toe and in the hand. Don't mention me thumb. Don't tell me the thumb.
No, little finger.
Little.
No,
If it is
sorry.
an emboli causing.
Index finger.
Yeah, it should be in line, no? That vessel which is there
Yes.
proximally emboli is coming, it should be in line with the proximal vessel. So it is an index finger, princeps
Index
pollicis.
finger.
So the vessel which
Yes.
goes here, there it is a great toe. Okay, yeah, fine. Sir, Rajiv, sir.
Okay. Now you said, let's go to the next slide, please. Blackish discoloration, both lower limbs starting, no cyclical change. What do you mean by no cyclical change? What did you want to find out about that?
Just want to rule out Raynaud's phenomena.
Okay. So what's Raynaud's disease then? What's Raynaud's phenomena first?
Sorry, sir.
What is Raynaud's phenomena?
Sir, Raynaud's phenomena is sudden spasm of the arterial vessels, digital vessels, due to exposure to cold. So that is Raynaud's phenomena. And when there is no known etiology found to that, that is an idiopathic cause. So that would lead to Raynaud's disease.
Okay. Okay, that's fine. So can you tell me conditions in which there is Raynaud's phenomena?
Sir, Raynaud's phenomena can be in collagen vascular diseases.
Right.
Then in cases of when there is no known cause to idiopathic, so it's a Raynaud's disease.
Okay, one is collagen. You have scleroderma. If
Yes.
people who use vibrators, vibrating instruments and kind of thing. Okay.
Yes, sir.
No complaints of trauma prior to blackening. No complaints of swelling, foul swelling discharge. Okay. Let's go to the next slide, please. Okay, tobacco. You said it's arteriosclerosis. What are the risk factors for arteriosclerosis which this patient has? Ashish? Hello?
Yes, sir.
what are the risks? You said this is probably because of atherosclerosis, isn't it?
Yes, sir.
So what are the risk factors your patient is having for atherosclerosis? What are the risk factors she's having?
Sir, first of all, patient is a tobacco chewer.
Okay.
Also, patient is a known hypertensive.
Mm-hmm. So you've got two of them, right? What are the other risk
Yes, sir.
factors for atherosclerosis?
Sir, the age of the patient.
Right. What else?
Then
I'll tell you. If you don't know, just tell us. I'll tell you. Let's not waste time. Okay.
yes, sir.
Dyslipidemia and diabetes mellitus. Okay.
Sir, in this patient, the patient is not a known diabetic.
Right. I said, what are the other risk factors which are not present in this patient?
Okay. So the other risk factors are the diabetes mellitus or hyperlipidemia
And right. Okay.
and
Next slide, please.
hyperlipidemia.
Right. Next slide, please. Hmm. 25 years back, open appendectomy and tubal ligation.
Yes.
Anything to do with this? Anything related
No, sir,
to this,
just
your
to...
patient? Okay. Next slide, please.
No, sir.
Next slide, please. No, you said she's got pain. Pain is more in the night.
Yes, sir.
Let's go back. Why do you think the pain is more at night?
Sir, at night when the patient sleeps, because of the lack of the gravitational pull which is present while standing, so that is gone. So when the patient sleeps in bed horizontally, so the
Okay, but she's also
the arterial supplied.
that's fine.
Yes,
That's
sir.
fine, Ashish. That's fine. But she's sitting, spending her night with her legs hanging down, isn't it?
Yes, sir.
So there's gravity there. Even the daytime she's sitting that way. Why do you think it's more acute at night? She's getting sleep at daytime.
Sir, because at night the surround atmospheric temperature is also low,
Right.
which causes
So it's cooler at night and
cooler at the night, and that's why the patient has more pain. And also at night it's
right.
all silent, so patient is
Right.
not
Very good. Very good. Very
distracted
good.
with the other
Okay.
atmospheric sound. So it
That's fine. That's fine. That's
causes
fine. That's
more
fine.
pain.
That's fine. It's okay. It's okay. It's okay. We got it. Why do you think this is not TAO?
Sir, in TAO, the patient is not satisfying the criteria for the
What criteria? What
TAO.
is the name of the criteria? What is the name of the
Shanoa's
criteria?
criteria.
Right. Very good. So what does Shanoa say?
Sir, Shanoa's criteria is says that the patient should be less than 45 to 50 years of age. That means it occurs in the young age. Then smoking is a risk factor for TAO. Then
Okay, tobacco. She's also got
diabetes
tobacco.
and
Hang on. Yeah, go on, please. Go on.
then patient shouldn't be having any diabetes or hyperlipidemia. Then also patient should have distal limb involvement and superficial thrombophlebitis.
Okay, that's fine. That's fine. So it should be just smoking or tobacco with no other risk factors and on peripheral limbs. No
Yes,
other
sir.
other organs are involved, right? Okay.
Yes, sir.
So please.
And infracochlear involvement.
Sorry, sir.
And infrapopliteal involvement.
Infrapopliteal involvement, yes, sir.
Arterial occlusion.
So, should we go to
Why
the
not?
examination, sir?
Yeah, sir.
Ashish,
Yeah. Examination.
what is neurological claudication? How will you
Sir,
differentiate it from vascular claudication?
Sir, in neurologic claudication, the pain does not decrease after resting, or sometimes it decreases, but after a long time. Whereas in vascular claudication, the pain decreases after resting.
And neurological claudication is at the first step.
Yes, sir.
Neurological
acts as a first.
claudication is first step. And one more point I want to add you. What you mentioned on all negative history, all these points in the previous 2 slides, that should come under the history of negative history. Because in clinical examination, what is more important rather than your diagnosis, your way or spectrum toward the excluding other differential is more important. They will assess all these points.
Okay, sir.
So that should come under the history of negative illness, negative history. Okay, proceed.
Yeah, examination.
On general examination, yes, sir.
Yeah,
on
continue.
general examination, patient examined in a well-lit room with patient seated in her bed comfortably. Sorry, sir, for the mistake. Decubitus is sitting upright with legs hanging down by the side of the bed. Her BMI is 23.5. Patient is conscious, oriented to time, place, and person, afebrile. Pulse is 100 per minute, regular, normovolumic, measured in right radial artery. Adequate force and tension, no radial or radiofemoral delay noted. Sir, the further details of the peripheral pulsations I would like to describe in the local examination. Then blood pressure is 126 by 76 millimeters of mercury, measured in right arm in supine position. Respiratory rate is 20 per minutes, regular, thoraco-abdominal. SpO2 is 97% on room air. No signs of pallor, icterus, cyanosis, clubbing, edema, or generalized lymphadenopathy. Skull spine appears normal. On oral examination, as the patient is a chronic tobacco chewer,
Why is Ashish this separate heading of oral examination for this case?
Sir, because patient is a chronic tobacco chewer.
It's all right. Has she got any symptoms?
No, sir. There's no
because
symptoms.
everything will get diluted. Everything will get diluted. Like that, yeah, even heart also you need to. She may be having IHD also. So things get diluted. I can understand if she has got a history of trismus. I can understand if she has got a history of tongue lesion, something like that.
Okay.
Anything
sir.
positive in this?
No, sir.
Okay, next.
Just
next.
Tobacco
Otherwise, things get diluted. We'll be wasting time for where it is really not required. Yeah, next slide.
Okay, sir. Systemic examination is essentially normal, sir. With S1, S2 normal, no murmurs, and in RS, air entries bilaterally equal, no adventitious sounds, and per abdomen soft, no organomegaly. On local examination, on inspection, both the limbs show blackish discoloration of toes, that is great toe of both the foot and second and fourth toe of right foot, shriveled up, mummified appearance up to proximal interphalangeal joints, where it ends up into well demarcated margin of normal looking skin and showing zone of hyperemia. On dorsum of left foot, shows a 1 into 1 centimeter ulcer with well-defined margins, punched out edges dried, and with pale floor, no slough at the floor. Then the transverse nail ridges were present and widening of the first web space seen. Skin over the lower part of the leg is thin and shiny with scanty hairs and very little subcutaneous fat. There were no dilated veins seen. Movements distal to the proximal interphalangeal joints were lost in all toes, whereas movements at joints proximal to the proximal interphalangeal joints are normal and in full range. On palpation, toes of both the feet are cold, non-tender, hard, and loss of sensation is present over the toes. Temperature over the foot and legs is normal. Ulcer is 1 into 1 centimeter with non-tender punched out lesions. Floor is dried, non-tender, moves well over the tendons of the foot. There's no edema or crepitations present over the foot. Sensations over the toes are lost. Rest of the lower body shows well preserved sensations and no lymph nodes palpable in the inguinal region. This is the palpation of the arteries. The dorsalis pedis, anterior tibial and posterior tibial arteries in both the limbs showed no pulsations palpable. Popliteal artery in both the limbs showed decreased pulsations, whereas femoral and all the upper limb arteries like radial, ulnar, brachial, axillary shows normal pulsations with pulsations seen in subclavian, common carotid, facial and superficial temporal. On percussion is not contributory, and on auscultation, no bruit is heard over the femorals, carotids and the abdominal aorta. Sir, summarizing the case, a 56-year-old lady, a chronic tobacco chewer and a known hypertensive, is complaining of severe bilateral lower limb rest pain and dry gangrene of bilateral toes with solitary trophic ulcer of 1 into 1 centimeter over left foot, showing signs of chronic limb ischemia with decreased bilateral lower limb arterial pulsations. My provisional diagnosis.
Will you come back to the inspection slides?
Yes, sir.
Okay, you mentioned in your presentation hyperemia at the junction. What is that you wanted to highlight?
Sir, it is a demarcation between the dry gangrenous part and the normal skin, which is due to the presence of the granulation tissue, which tries to separate the diseased part from the normal tissue.
So it's a granulation tissue, or what is the significance of this point?
Sir, it's a reaction of the body which tries to limit the diseased, the gangrenous part, causing inflammatory changes.
It's a specific for acute ischemia or a chronic ischemia?
Sir, it's for chronic ischemia.
What happens in chronic ischemia at that point? Dead and living. What is that nature tries to do it? To have a collaterals and tries to keep that under limitation by providing a blood supply.
Yes, sir.
Okay. And one more point you have mentioned, there is an increased space in the web space. So what is that point you wanted to mention in your presentation?
Sir, because of the decreased blood flow, the blood supply to the web spaces is compromised, and that's why there is widening of the web spaces.
What is there in the web space?
Sir,
how Ashish, how the blood supply, reduced blood supply will widen the web space? Can you explain that? You are right partially, but the
Ashish,
you are saying
Ashish, the
yes,
thing
sir.
is that you don't look. If you give a finding, you must have an answer, right? If you don't have an answer, don't show this finding, which is insignificant. I mean, widening of web space between toes. How the is it going to affect the management or your diagnosis?
We
No, sir.
It is
tend
just
to say it
unnecessary
is more of hollowing.
putting in something and you falling into a trap. Professor Jayalal has caught you. How does it happen? Now you give the expression.
It is not even
So,
widening.
Professor Jayalal, he can't hear you.
Yeah, it will be the hollowing of the space. That is one of the ischemic damage. The trophic changes is taking place in both the intraosseous muscles and the subcutaneous fat. So that's why it becomes a hollowing, not just widening.
Yes.
Okay, sir.
All the small
Go ahead,
muscles
go
are
ahead.
getting atrophied. So you have this kind of look.
Yes, sir.
Okay.
But what you are mentioning is shriveled and mummified, but the picture we are not saying that typically is it a whole the toe is shriveled and mummified, or only a part of it is there blackened?
Sir, only a part of it.
How can you then say it is a shriveled, mummified? You have only a blackening part. See, when their toe, when it is shriveled, mummified, that is a classical description. Here you are seeing blackening there, but I'm not able to see, probably clinically you would have seen, not seeing it typically to call it as a mummified and shriveled toe.
Okay.
Go ahead.
In your pulse examination, you commented that both the popliteal are decreased in flow.
Yes, sir.
Is it right? How did you conclude both the popliteal? I can understand if there is a comparison from on either side. So how did you conclude that there is a decreased flow in both the popliteal arteries?
Sir, it's decreased in comparison to the other arteries.
With which you compared that?
Sir, with the femoral artery.
You cannot compare femoral with the popliteal artery. Femoral is a bigger vessel, popliteal is a smaller vessel. So best way in such a scenario would be whether it is felt or not. This comes whether it is normal or abnormal only when you have a comparison. Is it not? So it's a bilateral disease. Is it felt or not? Popliteal arteries on either side. If it is a unilateral disease, then you have a comparison and you can conclude, yes, it is normal or decreased compared to opposite limb.
Okay, sir.
Okay. Sir, Jailal sir, good evening.
Good evening, sir. Good evening.
Okay, Ashish. Right.
Yes,
so
sir.
What's the diagnosis now? Okay. What's the diagnosis now?
Sir, my diagnosis is patient is a case of chronic bilateral lower limb peripheral vascular disease with dry gangrene of bilateral toes and trophic ulcer in a known case in a known chronic tobacco chewer, probably due to atherosclerosis.
Okay. Okay. So now how will you manage? You've got this patient in your OPD. How will you manage this patient?
Sir, first of all, I like to investigate the patient with blood investigations, starting with routine blood investigations of CBC, LFT, RFT.
How is CBC going to help you confirm your diagnosis?
Sir, just to rule out that the patient doesn't have any raised any infection, just to confirm my diagnosis of the patient not being
Is that important now?
Change.
Is that important now, or is it more important to make sure to come to a diagnosis first? CBC and all this, of course, sugar to just rule out diabetes. You know, she's not diabetic. She's told you. They are adjunct investigations, right? The primary investigation is to confirm your diagnosis. So how do you confirm your diagnosis?
So to confirm my diagnosis, I would like to do imaging tests with a color Doppler of the of bilateral lower limbs.
So what will you order? What will order color Doppler of bilateral lower limbs? It will come back. The radiologist will send your request back. What do you write?
Sir, I will write ultrasonography of bilateral lower limb with arterial Doppler.
Yes, so you write that. Okay. So what do you write? So what do you think you'll find in your ultrasound Doppler?
Sir, in ultrasound Doppler, I would see the if the calcifications or the atherosclerotic changes in the vessel, and to rule out any block in the vessel.
Look, Ashish, there are two. What are the two modes in which a Doppler is done?
Sir, in a duplex scan, it's a B mode and A mode. So
okay.
in B mode
so what do you
scan, in B mode scan,
there's nothing called A mode. Look, Ashish.
No,
it is B
yes,
mode
sir.
and Doppler mode, right?
Yes, sir.
Right. There's nothing called A mode. So what do you look for in B mode, and what does B mode tell you?
Sir, B mode of the ultrasonography shows more of the anatomy of the vessel.
Yeah. So what will it tell you?
The vessel wall and the flow of the blood.
No, flow of blood is shown by Doppler.
Yes,
flow
sir.
is shown by Doppler.
In B mode, I would mainly look at the wall of the vessel, and
yes, very good. One is wall structure. You see the wall structure.
Yes, sir.
Calcifications, any plaque, all that kind of thing.
Yes.
Second, what else do you see in B mode?
Any
if you're stuck, tell me, I'll let you know.
Yes, sir. Yes, sir.
Right. So most important is anatomy. You see the course and any variant, right? You see the vessel contour, aneurysm, any stenosis.
Yes.
Then you see the wall structure. You see the perivascular structures. If there's any hematoma, any abscess, right? And now what do you see in Doppler mode?
In Doppler, I would like to see any thrombus or any block. The site of any
Doppler
block.
will not tell you block. No, sorry. That is in B mode. It will tell you whether there's a plaque there or calcification. What does Doppler mode tell you?
The flow of the blood in the vessel.
Yes, you've got that flow velocity.
Yes, flow velocity.
Okay, what else? What else?
Any turbulence, if any, present.
Very good. Very good. So flow pattern.
Yes.
What else?
Sir, then we would see the phase of the flow. That is,
very good.
If the
very
blood
good. So
flow is monophasic, biphasic, biphasic, or triphasic.
Right. Very good. What else?
And
you're giving the answer, right? It is flow direction. Right?
Direction also.
And of course, it will demonstrate whether there's any flow at all or not.
Yes, sir.
Okay. So you've done this.
Yes, sir.
What is ABPI?
Sir, ABPI is ankle brachial pressure index.
So how is it done?
Sir, it is done with a handheld Doppler. And it measures the segmental pressure, and it's a ratio between the pressures at the ankle divided by the pressures at the brachium.
Okay. So,
sir,
now that the
normal
patient has
values,
got gangrene,
yes,
the patient has gangrene, what do you think
yes, sir.
is would the ABPI be?
Sir, as the patient would be having a ABPI of less than 0.3, sir,
0.3.
showing that the patient has a critical limb ischemia.
Okay.
What is
When
critically
you
missing?
examine the patient, sorry, when you
Yes, sir.
examine the patient, did you look for
Yes,
the
sir.
what is Berger's vascular angle? Did you look for
Burgess?
the vascular angle?
Yes, sir.
Did you check? Did you test for it during in the examination? I think you've
Sir, in this patient, because of the like the complexion of the patient, I couldn't clearly figure it out the paleness of the limb. But sir, in practice, in patients
no.
who
Hang on,
are
hang on, 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 hang on. It can become pale, but it can lead to pain also, ischemic pain. If you
yes,
lift the limb up at a certain angle, the patient will start getting pain. And you get what? Guttering of the
guttering of the veins.
veins. Why do you get that?
Sir, because uh, the arterial supply, it's decreased
Yeah, so okay,
to the
okay, good.
limb at a
Sir, please
critical
carry on,
angle.
sir. That's fine, that's fine, that's fine. Sir, please, sir.
What is critically missing? Ashish?
Sir, critical limb ischemia is when the patient exhibits changes of ulceration or gangrene when the ABPI is less than 0.3 and patient has changes of vascular arterial insufficiency or arterial ischemia such as loss of hair over the leg, then the nail changes,
And what is
shiny.
pre-gangrene? What is pre-gangrene?
Sir, pre-gangrene is mostly having uh, color that is hyperpigmentation, then edema, uh, and resting pain.
Resting pain.
So
Okay.
in pre-gangrene, you have all conditions except gangrene of the toes. Everything else is
Yes,
there.
sir.
That's pre-gangrene. Okay, which artery do you think is involved in this patient?
Sir, in this patient, most likely the arteries involved are the superficial femoral artery.
Why do you think it's superficial femoral?
Sir, because the pulsations below the level of the superficial femoral artery uh, are decreased or absent in this patient, and also
No.
the
Look. Hang on, Ashish. You're presuming this because you think the popliteals are weak, isn't it?
yes, sir,
While walking, the patient gets pain where?
in the calf region, sir.
In the calf region. So it could be at the popliteal also. Why do
Yes,
you
sir.
think it's superficial? There could be stenosis at the popliteal. As it is, popliteal is very difficult to palpate, right?
Yes, sir.
So it can be anything with at popliteal or above.
Yes, sir.
Okay. So you've done the Doppler. What else will you do
Yes,
now?
sir.
Have you got the Doppler report with you?
Yes, sir.
Could you just put it up?
I'll share the screenshot.
Okay. Or could you read it out? Just read it out then.
Yes, sir, I can read it.
Yes.
The Doppler report is suggestive of extensive atherosclerotic changes seen in the form of vessel wall calcification, intimal thickening, luminal irregularities, and narrowing. There is an atherosclerotic plaque causing significant luminal narrowing 5 centimeters from the bifurcation of left.
Ashish, it's a duplex or Doppler?
Sir, it's a duplex scan.
Okay. So you said Doppler. Go ahead.
No, sir. Doppler report I don't have, sir. This duplex scan report is there.
Go ahead.
The left common femoral artery and left proximal superficial femoral artery before the plaque shows normal color flow and velocity and triphasic waveform. The left SFA distal to plaque and left popliteal artery, anterior tibial and posterior tibial artery show low velocity, which is monophasic waveform. A short distal segment of left superficial femoral artery shows extensive calcification with shadowing couldn't be visualized. Sir, and then the waveforms of all the art vessels is given. So in left side, the superficial femoral artery.
It's okay. It's okay.
Yes, sir.
Fine. That's fine. Okay, so you've got a Doppler. Now, what else will you do? You've got a Doppler. How will you proceed now?
So, sir, as the Doppler shows atherosclerotic involvement of multiple vessels, so I would like to start the patient on medical management first. And
what
ask the
medical
patient
management?
for lifestyle changes as well as to
hang on, Ashish.
Yes, sir.
Now you'll get all those tests done. You'll get all the those blood tests done. Which other blood tests will you get done? Will you be hello?
Sir, I would like to do the routine blood investigations, including CBC, LFT, RFTs, complete lipid profile, blood sugars.
Anything else?
Then the ECG of the patient.
Okay.
Then
okay. Anything else?
Ultrasonography of the abdomen to look for any abdominal aorta, atherosclerosis in the abdominal aorta.
Of course, you'll find calcification and all. You know, I can't go on doing Doppler studies of the whole body. We are talking about the limb now. What else will you do?
Sir, CT angiography can be done for the patient.
Would you like to get a plain X-ray of the leg or the foot done?
Yes, sir. Plain X-ray would show the osteoporosis and decreased bony density of the bones.
How does that help you?
I
mean, she's 58. Obviously, she'll be osteoporotic. How's that? We're not getting it done to see for osteoporosis. We're getting it done for osteomyelitis.
Okay, sir.
Okay. What medical management? Okay, come up with the medical management now.
So, sir, for medical management, drugs to increase the pliability of the RBCs, and we use drugs like pentoxifylline, which increases the
Pentoxifylline is hardly
pliability.
used anymore. Pentoxifylline is hardly used anymore. Come up with the better ones.
Then drugs which decrease the platelet aggregation, such as aspirin,
Okay.
would be
What
used.
else?
Then to decrease the fat deposition, so atorvastatin or statins would be.
Right. Two important drugs. Silastocin and
Silastazole
atorvastatin.
and xanthin nicotinate.
And atorvastatin. These are the two most important. Others you can give.
Yes, sir.
What about pain? How will you relieve a pain?
Sir, for pain control, we'll start with NSAIDs first, and if the pain is not being controlled,
is that what is WHO pain ladder? Does it start with NSAIDs? Paracetamol.
Yes, sir.
NSAIDs. Then
if not controlled over NSAIDs, so we'll step up for opioids.
Not opioids. Synthetic opioids.
Synthetic opioids, yes, sir.
Opioids is the last resort. Why opioids is the last resort?
Sir, because they cause respiratory depression and.
Hardly. More important. She'll become dependent.
Dependent, yes, sir.
Yeah. Okay, you've done that. What else?
And sir, then if the pain is not also controlled on that, so we can consider the patient for sympathectomy.
Have you seen sympathectomy in your 3 years of working in your hospital?
No, sir.
Have you read about it?
Yes, sir.
Where have you read about it? It's not done anymore. Why?
Sir, because of
it's a dead surgery, hardly done. Okay, no sympathectomy. Why? Any idea? It diverts the flow from the
muscles to the skin.
It worsens it. Okay, so that's hardly
yes,
done.
Sir.
Okay, what about her gangrenous toes?
Yes, sir.
What is your intention of planning your treatment for this particular case? Is it to treat gangrene? Is it to prevent progress of the jaundice, gangrene? Or is it to cure the disease, what she has?
Sir, it is to decrease, it is to prevent the progression of the gangrene in this patient. Okay. Because the
so whatever is gangrenous, anything can be done for that? Nothing can be done. Whatever is dead.
No, sir.
Okay, fine.
No, sir.
Other than medical, what all you have mentioned to increase the flow, any other interventions which can help her out to prevent the progress of the gangrene?
Sir, then to change lifestyle modifications such as to decrease the tobacco.
I said interventions. Any interventions in a modern era can help her out.
Sir, giving hyperbaric oxygen therapy and
straightway coming to the point, any endovascular procedures will help her out to prevent the progress?
Yes, sir.
Name some endovascular procedures.
Sir, percutaneous transluminal stenting for any stenosis or any atherosclerosis. Or
can anything be done for the plaque? Endovascular procedure, anything can be done for the plaque?
Uh, yes, sir. Balloon dilatation can be done, or atherectomy can be done for the block or atherus.
Sir, Raju sir,
Ashish.
Kanagavel has asked us to, he said he has put a message
Okay.
5 minutes.
Right. So I'll just ask you one last question, Ashish. Is
Yes,
there
sir.
any guidelines? What is task 2 guidelines? Have you heard of it?
No, sir.
Okay. Read about it. TASC guidelines. That's fine. Thank you.
Okay, sir.
So should we call it?
Yes, sir. Yes, sir. I think we have one more case, probably.
Sir, we normally
So,
allow the student to ask any doubts if they have. Ashish, do you have any doubts to clarify?
No, sir.
Shilpa ma'am, are you with us? Would you like to give any comments? I think madam has left. Okay.
don't think she's there.
Thank you, Ashish. You stay with us for the next case to listen. And we
Ashish,
have
well done, Ashish.
so we have two students going to present for the first time in our forum, because the group in BJMC, they have the habit of having two students. So let us try that in our system also. So we have Dr. Saket Patel and Dr. Akshay. So both of them are kindly contributed by Dr. Pankaj Modi sir, BJ Medical College. So one of them will be covering up the clinical part and one of them will be covering up the history part. So good luck to you. Please go ahead with the case, doctor. All the best. Faculty, please take over.
Yes, sir. Thank you, sir. Good evening, sir. Good evening, faculties. My name is Dr. Saket Patel. This is Dr. Akshay Parakhia. We are third year general surgical residents under Dr. Pankaj Modi sir's unit. Thank you for giving us this opportunity. I would like to present the case. The case is 52-year-old male patient, chronic smoker, coming from Dhanera Disha, a place from Gujarat, who is working as a security guard and belonging to low socio-economic status. Coming to Civil Hospital Ahmedabad on 3rd February 2023 with chief complaint of yellowish discoloration of eyes and urine since 3 months. Patient was relatively asymptomatic 3 months back, followed by which patient complained of yellowish discoloration of urine, skin, and eyes since 3 months, which was insidious, gradual, progressive for 2 months, which later decreased, followed by increase in discoloration since 15 days. Patient had associated itching since 3 months. Patient also complained of pain, which was in right upper abdomen, insidious in onset, intermittent, dull aching, non-radiating, associated with meals since 3 months. Patient had associated nausea, anorexia, and apparent weight loss, which was not measured since 3 months. Patient had history of melena, 2 to 3 episodes, 15 days back. Patient did not give history of fever, no history of clay color stool or steatorrhea, no history of similar complaint in past, no history of bleeding per rectum or hematemesis, no history of jaundice or blood transfusion in past. Past personal and family history. Patient is a known case of BD smoker, 1 to 2 packs per day for 15 to 20 years. Patient is non-alcoholic, no history of tobacco chewing. Patient is on vegetarian diet, normal bowel, bladder, and sleep habits. No history of diabetes, hypertension, tuberculosis, jaundice, blood transfusion, allergy, or operative history. No significant family history. Summary of the history. A non-alcoholic, chronic smoker, 52-year-old male patient with yellowish discoloration of urine, skin, and eyes since 3 months, which was insidious in onset with waxing and waning. Patient had associated itching, nausea, anorexia, melena, apparent weight loss, and right upper abdominal pain. No history of fever or clay colors. I would like to pass on the general examination to Dr. Akshay Parakhia.
Good evening, everyone. On general examination, patient is conscious oriented to time, place, and person. Patient height is 182 centimeter.
Akshay, wait.
Yes.
What is your conclusion by your history?
Yes, sir. So from the history, my provisional diagnosis is obstructive jaundice due to periampullary mass of malignant etiology.
Directly? What is your conclusion?
Sir, patient has history of jaundice, which is for 3 months. Waxing and waning is there. Patient has history of weight loss. Patient has history of melena.
How do you know the waxing and waning?
Sir, patient complained of yellowish discoloration of urine and skin, which decreased in as per the relatives. The discoloration of urine and skin was decreasing in trend. First it increased and later it decreased, followed by again complaint of yellowish discoloration. Similar.
Half-life of bilirubin?
Sorry, sir.
What is the half-life of bilirubin?
Half-life of bilirubin is 20 to 30 days, sir.
So within 3 months time, the bilirubin, you were able to see the difference.
Patient was primarily able to see the changes in urine color and skin, but not in eyes.
No, Akshay. Waxing and waning is by improvement of symptoms. Most important is itching, increased appetite, and there can be an episode of melena, right?
Yes, sir.
Yes, when the ampulla, the tumor necrosis off. You can't appreciate decrease in jaundice in waxing and waning.
No, remember, it is not that jaundice or bilirubin level is going to reduce immediately. It is only the symptoms you are going to see. And again, don't go by the term waxing and waning is a feature of periambulatory carcinoma. It is a very, very rare phenomenon to see within a 3 months time. So you cannot make a diagnosis by perceived waxing and waning, which you are saying. But I couldn't, when you are presenting the case, we couldn't find any obvious reason. Within 3 months duration, you are able to make a diagnosis of obstructive jaundice by history.
Yes. Akshay, could we go to your first slide, please?
Sure.
Okay, next slide. So there is no vomiting.
So no history of vomiting.
Right? But he has pain.
Yes, sir.
Right. So what kind of periampullary carcinoma is painful?
Sir, it is, sir, if it is in late stages, if it has peri...
Okay, Akshay. What are the components of periampullary carcinoma?
Sir, painless jaundice.
Components. Sir is asking components.
Yes, sir. Periampullary mass includes pancreatic mass, which is within 2 centimeter of ampullary region, ampullary mass, distal common bile duct mass, and duodenal mass. All the malignancy within 2 centimeter of ampullary region are considered in the tree of periampullary.
Head of pancreas. Is head of pancreas included?
Sir, within 2 centimeter of ampullary region.
No, just answer to my question. Is CA head of pancreas a portion included in periampullary or not?
Yes, sir.
Yes. Now you tell me which component of periampullary results in painful surgical obstructive jaundice.
Pancreatic more likely.
Okay. Why pancreatic?
Why?
So pancreatic malignancy are more known to have pain as a component of symptoms.
Why?
Why?
Sir, pain centers are present in head of the pancreas, and there is invasion of head of pancreas first. So they will be painful.
It is involvement of the celiac plexus, isn't it?
Yes, sir. Celiac plexus.
So you have CA head of pancreas, which is painful,
pancreas,
and CA gallbladder, which is also painful.
Yes.
What is the pain center in pancreas? You said some pain center is there in the pancreas.
Yes, sir. Before, sir, it was initially considered at the head of the pancreas, but now it is not valid anymore.
So then why you want to say that answer? You know that it is not valid. Don't try to bring in that which is not on. Okay. Fine.
Yes.
Why is CA gallbladder painful?
Sir, I don't know, sir.
Usually associated with stones, that's why.
Yes, sir.
Okay.
Yes, sir.
Okay. Is there any vomiting?
More grilling from the Guru Shantappa sir. He is a little
Yeah.
keeping quiet today.
No, sir. Just I'm with all of you.
Okay.
Because
Akshay,
Rajiv sir
any
has
vomiting?
taken up, I'm keeping mum.
No.
Okay, no, sir, please carry on. Because there no. Please, sir, you're the
Nothing, sir.
invited.
Yeah, Akshay, just I wanted to know, you said at history level you thought of obstructive jaundice. Is it
Yes, sir.
right?
Yes, sir.
I would like to know, is it obstruction intrahepatic or extrahepatic? What you were thinking at history level, at this level?
Sir, at history level, sir, it could be extrahepatic more likely or intrahepatic. Sir, clay colored stool are not there. So I want to keep a possibility of intrahepatic cholestasis as well in this patient.
Then how do you differentiate if it is an intrahepatic biliary stasis or obstruction or extra? How do you differentiate at history level?
So at history level, patient will have clay colored stool and
not necessarily. What is that which will differentiate between intrahepatic obstruction and extrahepatic obstruction causing obstructive jaundice?
Itching itching will be present in extrahepatic jaundice, and the level of jaundice will be more in extrahepatic obstruction compared to intrahepatic obstruction.
Okay, give me one example of intrahepatic obstruction causing obstructive jaundice.
Sir, Rubin Billy.
We will not go into the depth. Is it a surgical cause or a medical cause?
Medical
cause.
Medical cause.
Medical cause. Most of the disease, like simple is hepatitis. Can they have obstructive jaundice in hepatitis of any cause, whether it is alcohol or viral?
Yes,
can they have?
Yes.
They can have. So intrahepatic cause, invariably they will have associated systemic symptoms in the form of fever, like a generalized weakness, patient becoming toxic. Sometimes they can go into hepatic encephalopathy, which these points are very unlikely if it is an extrahepatic cause. And with a short history there, here it is a long history. That is how it is like jaundice is like a mathematics when you get a case. First, you should know that patient has jaundice at history level. What I'm talking is history level. You should know that patient has gone jaundice, history level. Find out probably what is it obstructive jaundice or a non-obstructive jaundice? If it is obstructive jaundice at history level, you can find out probably where exactly intrahepatic or extrahepatic. If it is extrahepatic, you are thinking in terms of, you can find out is it a benign disease or a malignant disease at history level. What is that benign disease commonly can cause obstructive jaundice in an extrahepatic obstruction? Which is that benign disease? Choledocholithiasis versus malignancy. Yes. So what are the points you should elicit to differentiate between these two conditions?
Sir, choledocholithiasis is a benign condition where patient will have sudden onset of and colicky type of pain in abdomen associated with fever.
They will have a biliary colic. One. Second,
past history will be present. Past history of jaundice will be present.
Not necessarily. Anything. At a given case. Now, today they have come, you have to differentiate. At history, before you examine and evaluate. Second.
History will be, history of fever will be there, sir.
Exactly. Cholangitis. Features of cholangitis. Yes. If there are features of cholangitis with a colicky pain and a patient being female, keep a possibility of biliary disease. That is stone disease. Choledocholithiasis. You got the point?
Yes, sir.
And it can be intermittent. What is Charcot striate?
So Charcot striate is intermittent pain, intermittent jaundice, and intermittent fever, sir.
Exactly. So they will have a typical of Charcot striate if it is a choledocholithiasis with a short history. If it is a persistent progressive, think of malignancy. Okay. I'll give one more scenario. Patient is male, adult, alcoholic, persistent progressive jaundice. What is the commonest periampullary cancer you think in terms of? Recently detected diabetic.
Sir, head of pancreas malignancy.
Exactly. Pancreatic lesions, you should keep it in mind. See how things are like. If you do postmortem, most of it you can put exactly what is a likely lesion. If that is a situation, what is that history you will ask to know that yes, disease has advanced, disease has progressed. at history level? What is the history, will ask?
So history of weight loss would be there or not?
Every malignancy, they will have a weight loss.
So
To know
long-standing
advanced disease locally.
So long-standing complaint of pain, which had change in character suddenly.
What is that pain? Where exactly they will have more pain if it is advanced disease in obstructive jaundice?
So pain would be radiating more towards back.
Back pain, presence of back pain, not radiating, presence of back pain in obstructive jaundice. Likely that it is an unresectable tumor, likely that it is advanced, followed by distension abdomen. Why?
Malignant ascites, sir.
Exactly, has developed. Probably. Any other cause for ascites in obstructive jaundice other than advanced malignancy?
Sir, if in case of long history, cirrhosis would be there. It might cause portal hypertension and.
Maybe there, may not be there. Cirrhosis, portal hypertension with cancer, all imagination. Anything better explanation where they will have associated. Hypoalbuminemia.
Yes.
Invariably, they will have hypoalbuminemia. That may be the cause for ascites. Is it not? Yes. So these are the points you should consider at history level, keep a possibility. So at history level, what is likely? Probably it is obstructive jaundice because patient has got itching. Is it not?
Yes,
it has got itching. One of the important history to say that it is obstructive jaundice. Okay. And you think in terms of probably malignancy because the patient is elderly, weight loss, and a progressive jaundice. And you are thinking in terms of ampullary because patient has got melena. Is it not?
Yes.
Okay, fine. Examination.
Ajay, kindly note your point because you say jaundice occurs 3 months back, itching also occurs simultaneously.
Yes, sir.
And 15 days back, you had a melena, and 15 days back itself, the jaundice started increasing. Is there any concordance or discordance on that? And when you get melena and when you start increasing in the jaundice?
Sir, when we have melena, jaundice will decrease for a time being.
But you are saying 15 days back it started increasing, and
Yes,
15 days back melena, and itching will not come all of a sudden. If you have a jaundice, hyperbilirubinemia, then after some time only the itching will come. So you should elicit the history in a way that you are presenting in a proper chronological order, not just say everything happened within 3 months.
Yes.
Okay, go.
Okay, Akshay, you said that a patient with obstructive jaundice will have, or periampullary carcinoma will have melena. So
Yes.
which component of periampullary carcinoma most likely causes melena?
Sir, polypoidal growth in ampullary region, which is...
It's very rare, very, very rare. And it's such a small thing that it hardly causes any bleeding. Come up with a more likely answer.
So sloughing off of the malignancy of the tumor cells at duodenal level.
Right, duodenal malignancies. Or see a head of the pancreas which has involved the duodenum.
Yes.
These two are more likely to give rise to melena.
Yes.
Suppose the patient had features of obstruction, vomiting. What kind of periampullary would you think of?
So duodenal malignancy, which is causing outlet obstruction, sir.
Duodenal malignancies hardly cause outlet obstruction. More common?
Sir, pancreatic head malignancy, which is...
right, see a head of pancreas.
Yes, sir.
More common, right? So, okay. Should we move to examination?
Examination.
I would like to pass on to Dr. Akshay Parakhia for examination.
Yeah.
On general examination, patient is conscious oriented to time, place, and person. Height is 182 centimeter, weight is 60 kg. Icterus present, no lower conjunctival pallor, no cyanosis or clubbing, bilateral pedal edema present, no lymphadenopathy. On examination, temperature was normal, pulse rate 62 per minute, blood pressure 110 by 80 millimeter of mercury, bilateral air entry normal. On per abdomen examination, on inspection, there was fullness in right upper abdomen, and yellowish discoloration noted over abdominal skin. Umbilicus is central and inverted. No dilated vein or any skin lesion around the umbilicus. No scratch mark. External genitals normal. On palpation, there is right upper abdominal lump palpable with palpable liver 2 centimeter below the right costal margin, which was soft to firm in consistency with smooth surface, and well-defined smooth globular lump of 2 by 2 centimeter in size, which moves with respiration. No other organomegaly. Liver span was 12 centimeter. Normal peristalsis. Per rectal examination normal, and the external genitals and hernial sites are normal. The differential diagnosis will be perimeter. Yes.
Yeah. Examination findings, please.
Examination findings. Inspection.
Yes.
You have not mentioned about left supraclavicular area, spine.
Sir,
Your inspection is not complete.
in general examination, sir, there was no lymphadenopathy.
What are the
You have
points
to mention
for inspection of the abdominal lump or any abdomen? What are the points for inspection?
Sir, on inspection, if abdominal lump is visible, if any fullness or lump is visible or not, if a lump is moves with
Unless
respiration,
and until we include the spine, left supraclavicular, lymph node, genitalia, abdominal examination is not complete.
It is definitely part of your examination. You have to say separately.
It is a part of your
Don't mix it with the generalized lymphadenopathy. Supraclavicular node, spine, all this.
There are 4 points.
Sir, used to say 3S: scalp, spine, scrotum. All 3S you need to. That's supraclavicular. 4S you need to include in that.
yes.
Okay, next slide. So what do you think is this lump?
It is more likely to be distended gallbladder, which is palpable.
So you can just say that it's you can palpate the gallbladder.
Instead
of saying soft, smooth, globular, just say go with a palpable gallbladder. Okay.
You have mentioned as the liver is palpable.
Normal peristalsis. What do you mean by normal peristalsis?
3 to 5 peristalsis per minute.
So that's a palpatory finding.
No, sir, on auscultation.
You written in palpation.
No, in the first line you have mentioned as palpable liver, and then you have said no hepatomegaly. How will you explain?
Palpable liver 2 centimeters below costal margin. Then he said there's no liver span 12 centimeters. What is the normal liver span?
So 14 to 15 centimeters.
Where, at what level?
Okay.
So
Akshay,
5th intercostal space to
Akshay.
Yes, sir.
That's why whenever you prepare slides, see how you are inviting questions now. There are findings in the abdomen. Okay, there are findings. So once there are findings, you should be cautious in using the other words like a normal abdominal examination. Don't go on just using words, some words like you have written no organomegaly. Is that not an organomegaly what you have felt? Even if it is a gallbladder mass, is it not enlarged? Is it not the normal organ gallbladder? It is not enlarged. So routinely you should not go on using the words. You have got some findings, stick to those findings and forget the remaining, that normal entity.
Yes, sir.
As a surgeon,
Akshay, you should recheck before you present
the positives.
You should recheck the slides. Recheck the slides before you present. Looks like probably, I may be wrong, looks like somebody has prepared for you and you are presenting the case. If you're honest, you should tell us this. I did not get the reply from you, Akshay.
No, sir. No, it is not.
Okay, fine. What is that you are not important finding in the abdominal examination? You are not mentioned till in
Very
the
important
abdomen.
finding is missing.
In the abdomen, in this case.
Sir,
I will not ask leading
any
questions.
fluid?
What was the finding? You should tell us which is that important examination finding.
so
Which you have one finding in the general physical examination, you have mentioned that finding. To correlate that finding, you should have mentioned one important finding in the abdominal examination, which is not there. What is that?
sir, free fluid.
Exactly. Exactly. Okay. Exactly. Presence of free fluid. If it have gone palpation, percussion, auscultation systematically, probably you would have picked up that. Is it not? Important, which we have discussed already. What are the causes for free fluid in a case like this?
Yes.
Okay. Why do you say, like it is undergraduate question, why do you say this 2 into 2 centimeter size mass which is felt is the gallbladder? I say it is a liver nodule. What you are feeling. So how will you disprove it?
Sir, yes, sir, on palpation, on percussion, this globular mass is not in continuation with the dull note of the liver dullness.
Means is there any gap there between the dullness of this and dullness of liver? Is there any resonant note there in between?
Both are dull, you know.
How do you say this is a gallbladder, not a liver nodule?
What is the characteristic of a gallbladder? What a palpable gallbladder? Just say that. What is characteristic? How do you know this is a gallbladder?
Gallbladder will be palpable on deep expiration. Deep expiration, it will move with.
No. Gallbladder, if it's already palpable, you're saying it's palpable below this thing. There's nothing to do with respiration here.
I don't know.
कभी gallbladder palpate किया हो?
Yes, sir.
How does it feel? What do you palpate? What does it feel like?
So, round body, smooth round body will be palpable.
Smooth globe structure. Is there any liver nodule which can hang on like that to the liver?
Sir,
it can't.
Akshay.
It will be in continuity with the liver. The gallbladder is slightly out. You can feel the sharp margins of the liver, and then you get a globular thing. So that's a gallbladder, isn't it?
Akshay.
Can it be a mobile structure transversely if it is a distended gallbladder? Can it be transversely? Can it be mobile?
No, sir.
It will move transversely like this.
No, sir.
Of course. Gallbladder is mobile transversely also.
It not. And where exactly it will be felt in relation with the rectus?
Sir, on the lateral border of the rectus and more towards the right lumbar region if distended.
Lumbar region.
Where? What is the one more lateral border of the rectus and what is the one more anatomical point which should transect, and that's where you need to palpate.
It's costal margin and sir.
Exactly.
Right,
exactly.
Lateral border.
These are few points. One, the palpable mass at the junction of lateral border and the costal margin, globular, can be moved transversely, soft consistency, moves with the respiration. See all points in order. Is it not? Okay. You have described the liver. You have described the liver. What do you think that liver pathology probably with the findings, whatever you mentioned the findings?
So it will be hepatomegaly, likely due to sir back pressure, stasis, biliary stasis.
Biliary stasis. Why do you think so? Why not a disease process with deposits? With your clinical findings.
Liver span is reduced.
Surface was smooth, sir. No nodularity.
Okay. Is it tender hepatomegaly what this patient has?
No, sir. Non-tender, sir.
Okay.
Akshay.
Yes, sir.
You mentioned in palpation that there is a normal peristalsis. Which word is appropriate here? Normal peristalsis or visible peristalsis?
So
Why
visible.
you are unnecessary making such blunders, particularly for PG exam?
Yes, sir, it should be
On
no
palpation,
visible
there is a
text.
visible peristalsis. So in which condition you are getting visible, you will get the visible peristalsis?
Sir, in gastric outlet obstruction because of pyloric stenosis.
Then
Visible. Sir,
then next.
Sir, if a chronic inflammation due to tuberculosis at IC junction, visible.
Why you are inviting problems? There are three conditions. In hypertrophic pyloric stenosis, this is from left to right. And in transverse colon malignancy, from right to left. And in small bowel obstruction, step ladder patterns. These are simple questions and easy to score.
What's your diagnosis, Akshay, now?
Sir, it is obstructive jaundice, likely due to periampullary.
Where exactly periampullary? Which one you will choose?
Sir, I will choose lower CBD.
Likely site. Lower CBD. Okay. How do you substantiate now with your history and clinical examination findings for your diagnosis?
Sir, I
put
will
the next slide. Next slide. Yeah.
So I will do blood investigation in which liver function first CBC. I will look for WBC count if it is raised or not. Then bilirubin LFT, sir, total bilirubin level, direct bilirubin level, alkaline phosphatase, APTT, PTIN. And then I will go for USG abdomen pelvis.
Albumin you did not mention in the LFT.
Yes, sir. Serum protein albumin. Yes, sir.
Yeah, you should. You should. PTINR and albumin, very important factor. Obviously, bilirubin will be high. Obviously. Okay.
Yes.
But in your examination, confirmation of your finding or the diagnosis is more important. So the first you always talk about the confirmation, then you go ahead to all that when it's necessary. So don't start with like an undergraduate, I will do the blood hemoglobin and then I will go ahead. This we are repeatedly saying in this class. So please follow. That is our intention is only for to go for the diagnosis and whatever you do. You are preparing for ultrasound?
Yes.
Yes.
Okay. What finding you are going to get?
So on ultrasound, liver was enlarged, suggestive of fatty liver, dilated central and peripheral intrahepatic biliary radical, left hepatic duct.
Just a minute, Akshay. Kindly note here the liver span is 16 centimeter.
Yes.
Your clinical examination, you said it is 12 centimeters. So there is something wrong in your clinical examination. So the way you are examining, whether you are coming down in the midline or the midclavicular line, or you are going towards the anterior, axillary line. So you please check with that. Because when you say 2 centimeter liver palpable and 12 centimeter, nobody will accept that. Okay.
Left hepatic duct 7.5 millimeter, right hepatic duct 8 millimeter, common hepatic duct 16.5 millimeter, CBD dilated measuring 22 mm in proximal part, 18 mm in mid part, and 15 mm in distal part, showing abrupt tapering in distal most part of CBDs. So wall of biliary duct in distal most part appears thickened and edematous with raised vascularity, approx 6 to 7 mm. So thickness, wall thickness. Portal vein normal, gallbladder distended with multiple calculi, average size of 4 to 5 millimeter. Spleen appears enlarged and so normal in echo texture. Visualized head and proximal body of pancreas are normal in size, shape, and echo texture. Para-aortic region is obscured, both kidneys and are normal, and mild fluid in peritoneal cavities.
So what do you think with this sonography report? Probably?
Probably distal CBD malignancy, sir.
Is there any possibility of having stones in the distal CBD and giving this report? Because there are gallstones?
Yes, sir. But sir, they have mentioned increased vascularity. So,
Okay. In the lower CBD.
yes.
Okay, fine.
Then we have done CCT abdomen pelvis, which is suggestive of gallbladder distended with multiple calculi in body and neck region, hyperdense calculi of 6 mm in a mid common bile duct, marked dilated common bile duct, common hepatic duct, and right and left hepatic duct with intrahepatic biliary radicals are also dilated, sir. And size are the same as mentioned in USG, sir, dilatation. And sir, mild free fluid in peritoneal cavity. Sir, liver is normal, pancreas is also normal. And sir, MPD, they have mentioned 1 millimeter size, sir, normal, and mild fluid in pelvic cavity, sir.
So there is a stone in the CBD.
Yes, sir. Clinically, we were suspecting malignancy, so we have done ERCP.
So these are the CT plates of CCT abdomen. Over the red, we have marked distended gallbladder. There is green marker which is suggestive of dilated common bile duct. Liver appears apparently normal. No lesions are seen in liver. Sir, this is the arterial phase of the CCT abdopelvis, which we can see from the vascularization of aorta. We can also see superior mesenteric artery, which is looking apparently normal. And the reports also suggested that all vessels, large vessels, which included SMA, SMV, portal vein, were normal. This is the venous vein,
Akshay. Yes. Now that you think this is this is not a malignant condition, if you go back retrospectively, could you have picked this up in your history or your examination? Anything which is in surgical obstructive jaundice or in malignant conditions, what do you think is characteristic? What are the characteristic findings which suggest that this is malignant rather than benign?
The patient's history was short. It was only 3 months, but all the other history was pointing towards malignant etiology because patient had weight loss. Melina was also there, and sir,
what about itching? What about itching? What about itching?
Sir, itching was also present, which was correlating with the waxing and waning of jaundice.
But you didn't find any itch marks. You didn't find any itch
no, sir,
marks on the.
No itch marks were present on the abdomen. No, sir.
So it's not that means that itching was not very significant.
Yes.
Right.
How do you explain her palpable gallbladder if it is a stone disease?
Sir, if it is a stone disease with palpable gallbladder, it could be due to a stone which is impacted at the neck of the gallbladder as well as in the common bile duct. It could be due to a stone at Hartmann's spout. And sir, it could be due to Mirizi syndrome. Less likely in this patient because this patient is old age, but it is a possibility.
So what is that palpable gallbladder is now if there is an impacted stone at the infundibulum?
Sir, it is mucocele of gallbladder, and if patient has fever and tenderness, then I would suspect pyocele of the gallbladder.
No, we will not bring that pyocele into discussion. So what is that gallbladder in this case now?
Mucocele.
Probably it is a mucocele of the gallbladder. Yes, okay. Sir. That is called double impaction.
Yes.
One at CBD, one at infundibulum.
Yes.
Okay.
And sir, over this is the venous phase of the CCT abdopelvis. Over the green marker is the dilated common bile duct. Sir, red marker is a query lesion over the distal part of common bile duct, which radiologists said that that was ill-defined lump, which they could not measure. After we did CCT abdopelvis review, because clinically we were suspecting malignancy and USG and CCT was suggestive of choledocholithiasis and gallbladder stones. Followed by which we went for ERCP of the patient. We first told the gastroenterologist to go for side view duodenoscopy, and over side view duodenoscopy they could see a mass near the periampullary region. And sir, they took a biopsy of that lesion and they did biliary stenting. of that patient. Sir, ERCP report is suggestive of periampullary mass lesion noted with ulcerated mucosa. Common bile duct was selectively cannulated on contrast. On contrast, grossly dilated common bile duct with IHBR dilated. Sphincterotomy was done. Large amount of bile was drained. 10 into 10 centimeter double pigtail stent was placed and free flow of bile was confirmed. Sir, periampullary mass lesion biopsy was taken, stenting was taken. These are the photos of.
Were there any stones during ERCP? Hello, Akshay. Were there any stones they could extract while doing ERCP?
No, sir. They have not mentioned about stones, sir.
Because nowhere they have mentioned that the stones were extracted while doing ERCP.
Yes, sir.
Fine. Okay.
So the periampullary mass biopsy we reported, which was suggestive of moderately differentiated periampullary adenocarcinoma.
So what is a lesson learned out of this?
So history is more important than radiological investigation. We should follow history and clinical examination first. And then if it is not matching with the radiological findings, we would review the radiology and as well as go for further invasive investigation if non-invasive investigation are fruitless to us.
Okay. If MRCP would have been done before submitting the patient for ERCP, it would have given some extra information?
Yes, sir. MRCP would have given extra information, but we already did contrast enhanced abdomen pelvis, where we were suspecting malignancy. So we
after CECT abdomen,
yes, sir,
doing MRCP would have given some information before ERCP.
No, sir. It will not give any extra information. It will only suggest the anatomy of the biliary duct system. If Mirizi syndrome was present, then it can be dealing.
Yeah, that is the right word I expect. The anatomy, if we have an ambiguity in understanding the anatomy with other imaging, MRCP would have been the better investigation. Here, the question was not with the anatomy, the question was with the pathology. So even though there were CBD stones. So rightly, after CECT, what you have done? To check and get the stones out and get the biopsy done, ERCP is the better option. Like that, these are the indications for doing ERCP in obstructive jaundice. Otherwise, not many indications. Not for the diagnosis purpose. Don't mention ERCP for the diagnosis of obstructive jaundice. Okay.
What is bilirubin level?
10.8 total bilirubin and 7 direct bilirubin.
After stenting, sir, total bilirubin was reduced to 4 and direct was 2. Reduction from 10 to 4.
How much time it taken?
Sir, we repeated the blood investigation after 3 days of ERCP.
So what will you do now with this report? You have done a biopsy, you have a report mentioning that it is adenocarcinoma, and on CECT, it is a localized tumor.
Yes.
Any other tumor marker you do, or you will go ahead with that?
Sir, we should have done CA 19-9 in this patient. So it was not
fine. You are not done. Now there is a CT source. There is no node, nothing. It is almost a localized disease. So what is your plan you will have for this?
So we'll go for a Whipple's procedure, pancreatic or duodenectomy.
Oh. When you are planning for it? Now you are already stented it.
Yes, sir.
So what other prerequisite? How will you prepare the patient for Whipple's?
So first of all, patient's albumin is low. It is 2. So we will supplement with albumin. And
so what will happen when you are supplementing with albumin?
Sir, it will improve the patient overall general condition, and we are going to do 3 anastomosis.
No. Will it increase the albumin level of the body? So any amount of exogenous albumin is not going to increase the albumin, because albumin has to be prepared only by the liver. So when your albumin level is very low, The amount of albumin you are giving is only can maintain the oncotic pressure, but not the albumin. So now already you have done a stenting, so that you are going to relieve the pressure. Now the liver will start functioning normally and produce albumin. So you need to wait for some time. It's not an exogenous. Minimum 6 weeks time you need for the reticular endothelial system to recoup, recover, and start preparing its own albumin. So level of albumin is very significant at this point. Your bleeding time, prothrombin time, so normal?
Yes, sir.
Yes, sir. Normal. Sir.
Okay. So what's the complication of this stenting? Now you are done the stenting and you are going for Whipples. Is there any problem with that? Or?
It can cause ERCP-induced pancreatitis.
No, not ERCP procedure. Putting a stent before the plan of definitive surgery, what are the disadvantages?
Sir, it will cause infection. If we are going for anastomosis, it will increase the chances of infection.
So what is that it causes? Infection means?
Ascending cholangitis.
So how does it come in the way of your surgical procedure?
Sir, CBD will be inflamed, so suture might not hold, sir, during anastomosis.
Not only suture holding, you will have a difficulty in dissecting around CBD. Pericholangitis. Okay, one. Second, disadvantages. Second, what is that you want from the CBD when you do anastomosis?
It should be dilated enough to do anastomosis.
Yeah, what happens if you put a stent?
Diameter will decrease.
It will be decompressed. So difficult to have anastomosis in a decompressed tubular structure. Decompressed tubular structure. Okay. You have mentioned on imaging pancreatic duct size is normal. Will it come in the way of your surgical procedure?
Yes, sir. We will not be able to do pancreatico-jejunostomy. We have to do dunking.
Okay. Not able to. It is what you probably want to highlight is duct mucosa anastomosis may be difficult. May be difficult. So dunking will be the better way of doing it. Fine. Okay. What are the other way you will prepare this patient for Whipples other than albumin? Like Jailal sir said, no? Yeah, you need to have 6 weeks. Better give a enteral feeds rather than your parenteral feeds. Give a enteral feeds so that albumin will improve. After that, you plan. Any other preparation you would like to do before you plan?
Hydration should be maintained to prevent.
Reason for maintaining hydration.
Sir, to prevent a hepatorenal shutdown.
Okay, very good. Anything else?
High glucose diet, sir, for buildup of liver.
Okay. If patient had a coagulopathy.
So if the patient has coagulopathy, I would like to go for injectable vitamin K for 3 to 5 days. We would like to give dose. If later on I would like to repeat the coagulopathy profile, if the coagulopathy profile is still on the higher side, then I would like to go for fresh frozen plasma infusion, transfusion.
Okay. If a total count would have been 30,000.
Then we will suspect cholangitis, and in that case, we have to do preoperatively stenting, which we have done.
Which is the best way of treating cholangitis in an obstructive jaundice? Before you plan your definitive surgery.
Higher antibiotic and stenting preoperatively.
Is it stenting or something else for a biliary drainage? Because stents are going to induce cholangitis and they will have a difficulty in dissecting. Maybe you can do serious cholangitis. You want to do something 2-3 days and take it out and plan your definitive surgery. What is that you will be doing? Keep it for 2-3 days and take it out.
PTBD.
No. Invasive you should avoid. Invasive in the sense putting some needle, something you should avoid. Nasobiliary drainage. So if your plan is definitive surgery within few days, so decompress that infected biliary system by means of nasobiliary drainage. rather than putting a stent there and inducing infection. Okay. So what is that being done in Whipple's? You think it is going to be easy getting away Whipple's? This lady, this patient?
No, sir.
Yeah, probably yes, because it is limited to the ampulla and not many lymph nodes. No, Whipple's is simple, but yeah, compared to other cases.
It's a grossly dilated CBD. It's a 2.5 centimeter. And pancreas is normal.
Just can you,
Yes.
sir, let them mention the steps of Whipple's, sir.
Yes,
Jailer,
yes,
sir.
yes, definitely.
You should mention 5 or 6 steps as if we are witnessing your surgery on the screen just now. Like that, you should mention the steps.
Yes, sir. Sir, first of all, I would like to go for extensive cauterization. First, a prepared patient is brought to the operation table. We would like to go for upper midline incision or chevron incision in the patient. Followed by which I would like to see if there is free fluid or not, and if the liver has metastasis or not, peritoneal or liver metastasis or not. If there are no liver or peritoneal metastasis, no free fluid, no ascitic fluid, then I would like to go for extended cauterization in the patient. After extended cauterization, I would like to see if the pancreatic mass is resectable or not by confirming whether it is encasing superior mesenteric artery or not.
Why you are particular about superior mesenteric artery, not the vein?
The vein can be, sir, vein can be involved. Part of vein can be resected, and reanastomosis or grafting can be done.
What is the difficulty in reanastomosing an artery?
Sir, continuous.
No, artery can be also reanastomosed. You can have a patch. No, idea behind this because once it is artery is involved, it is a perineural invasion will be there. So the artery, the nerve endings are surrounding that artery. So that denotes inoperability or the case is not fit for surgery. It is not just because an operable difficulty of anastomosing an artery. It is indicating that it is a nerve involvement and it is going for a not a curative purpose surgery we cannot do. So once you see SMA involvement, so you are going to abandon the surgery. Go ahead.
So once the pancreatic dissection is, if the pancreas is not encasing superior mesenteric artery, I would like to go for fundus first cholecystectomy, followed by which I would like to go for Callet's dissection. Separate the common bile duct, portal vein, hepatic artery. Go
the gallbladder, or you will keep the gallbladder there?
I will keep the gallbladder for retraction, sir, initially. So later on, I would like to first confirm the arterial anatomy. I would like to go for common hepatic artery dissection, which I would go downward distally up to the upper border of pancreas. Check for gastroduodenal artery, ligate the gastroduodenal artery, and then cut the gallbladder and common hepatic duct. Then I would like to go for I would like to do gastrectomy. Distal part of gastrectomy I would like to do, and lower side, distal part of 10 centimeter from DJ flexure I would like to transit. And then, sir, I would like to separate the mass from the superior mesenteric artery and take the mass out. And then I would like to go for anastomosis. First pancreatic jejunostomy, then hepaticojejunostomy, and then gastrojejunostomy.
Yeah, Akshay, I hope you understood the procedure nicely. But my expectation was not straight away putting an incision on the abdomen. Whenever you plan radical surgeries like this, it is better to put a scope inside. Even though you have done imaging and proved that there are no deposits, put a scope and confirm whatever you said, like peritoneal deposits, diaphragmatic deposits, surface deposits on the liver or a peritoneal fluid. So put a scope, see if any doubt, take and send for frozen, and then plan your definitive surgery. That's what my expectation was. Because it's a radical procedure. After opening the abdomen, you should not see a surprise there are deposits.
Yes.
Is it not? So it is better to put a scope and then take a decision of doing a definitive surgery. Second, I expected was what is cattle brush maneuver before you start cauterization?
Yes, sir. Right side of the large bowel mobilization. Yes, sir.
That is the first step what is being done. You will have MCQ for your specialty examinations after MS.
Yes,
That is the first thing what is being done before in Whipples. Cattle brush. You mobilize the hepatic flexure, turn everything on the left side so that only what is seen is duodenum and head of the pancreas. Then your second step would be cauterization. Is it not?
Yes, sir. Yes, sir.
Yeah, fine. How will you identify the portal vein during transection of the pancreas?
So portal vein would be posterior to neck of the pancreas.
So how will you identify? From where you will start the dissecting to identify the junction, splenic and superior mesenteric, and then up transecting the pancreas. How will you start identifying?
So over the superior border of pancreas, sir.
Superior border.
No. Superior border. How will it?
So first, when we are
You start from a smaller structure and then go to that, or you start identifying where it has already formed.
So when we are going to create tunnel behind the pancreas, at that time, sir, from superior mesenteric vein. And
exactly, you should trace that. What is the advantage of tracing superior mesenteric vein underneath the neck and then getting that junction of splenic and superior? What is the advantage? What is that nature is helping us?
So
there are no draining veins. There are no draining veins over the surface of the superior mesenteric vein.
So tunnel of
Anatomically, there are no draining veins. You can straightway dissect. So that is how the nature is helping the surgeon. There are no draining veins. They are lateral and posterior. Okay, which is the most difficult portion of this surgery when it comes to pancreas before you resect?
Making space between posterior surface of pancreas.
I said there are no veins. There are no draining veins. It is most difficult of the pancreatic portion to be resected out, where it can bleed a lot.
So uncinate process, jejunal veins are.
Exact. Okay. My last question, Jailal sir, would be, what is artery first method, Whipples?
Sorry.
Check, you have already said.
When do you do it and what is it?
I don't know, sir.
Okay. Which is medial, which is lateral? Vein and artery. Which is medial, which is lateral?
So vein is medial, artery is lateral. Yes, sir.
Lateral. So far away from the artery.
Yes, sir.
If I say artery first method, means what?
From tail of pancreas, we are.
No, forget about tail. If I say artery first method, means what?
We will ligate.
Yeah, you are going to tackle the artery before you start mobilizing or resecting anything.
Yes.
You're going to tackle that artery. Okay. If that is the case, what type of tumors it should be done?
Body of pancreas tumors.
Not body, neck. There has to be small normal area in the ligation of the artery. There should not be a tumor there.
Yes.
There should not be a tumor there. So it is a head and neck lesions, bigger lesions, head and neck lesions. Okay. Sir, Jailal sir, anything, sir?
No, it's
Sir,
fine.
Akshay,
Now, how will you? What are the
sir,
complications?
can I ask?
You are doing a Whipples?
Sorry, sir.
What are the major complications you are expecting?
Sir, gastroduodenal artery stump disruption causing hemorrhage.
I'm not asking surgical. No, you have done a surgery.
Yes, sir.
You have completed the surgery.
Yes, sir.
In the post-operative period, and what are the things you are expecting?
Yes, sir.
So hemorrhage leading to blood.
What are the major complications you will?
Yes, sir. Sir, pancreatico-jejunal anastomotic leak.
How do you identify anastomotic leak?
Sir, first initially patient will complain of abdominal distension, high output of drain incoming, and sir, drain output fluid is colorless or white in color. which we will go for drain amylase and lipase, which would be more than 10,000. That would be more sensitive for pancreatic duct leak, sir.
Okay. Anything with renal problem?
So patient is more likely to go for acute kidney injury because supramajor surgery is.
So how will you prevent that?
Sir, pre-operative adequate hydration, intraoperatively fluid monitoring, and post-operative fluid monitoring would be, we will be giving, and we will be giving colloids over crystalloids.
Okay.
And if there is blood loss, blood products more preferred to crystalloids.
So this patient, and after that, post-operative is comfortable, no complaint, and how we are going to follow up the patient? But biopsy report is also coming. It's an adenocarcinoma.
So if required, chemotherapy will be needed for this patient.
What chemotherapy will be normally giving?
Cisplatin, gemcitabine, and 5-fluorouracil.
So what is the prognosis you are expecting?
Sir, 22 months survival post-Whipple's procedure.
Suppose you are going there and you are not able to do the Whipple's. I mean, any other option you have now?
The triple bypass procedure, if we have already opened the abdomen, sir.
No, already you have put a drain and it is coming down. Then why do you want to do a triple bypass now? You already put a ERCP stenting. It is still working there.
So then, sir, no. Sir, if we preoperatively know that it is inoperable mass, then for a biliary stasis, we can go for stenting that we've already done. And if patient develop a gastric outlet obstruction, for that also, if patient is affordable, we can do metallic stenting. And if not affordable, then we'll do gastrojejunostomy.
Patient says he has intractable pain.
So for that, celiac plexus block can be given. First, we start with a tramadol, and then if still intractable, then we can give celiac plexus block.
Okay. Other options you have? Block means how do you do the block?
So block, sir, by first in T12 region, in prone position at the level of T12 and L1, we will insert the spinal needle, and then we'll inject the fluorescent dye to identify the location. Sir.
Under what guidance, Akshay? Sir is asking under what guidance?
Guidance.
Like that, you will just palpate and put the needle, or you use some image guidance?
It's a USG guided and CM fluorescence guided in our setup. Sir. And then we will first give lignocaine. Give lignocaine to see whether the effect of block is coming or not, and if effect is coming, then we'll give 100% alcohol.
What is that called? You are given a xylocaine and you have some results. You are given an absolute alcohol, you will get some results. What is that called? The A and the B. What is that first one called? What is that second one called?
Sir, celiac plexus chemolysis.
Chemical neurolysis.
Neurolysis, the second one.
Yes, sir.
With absolute alcohol, you are going to cause the damage so that you will have a longer relief. The initial one, it is only the block, just to check whether you will have a relief or not.
Yes.
That is called chemical neurolysis.
Akshay?
Yes, sir.
See, what is the precaution you have to carry out before ligating the gastroduodenal artery?
So first we'll ligate gastroduodenal artery and then see the pulsation of the proper hepatic artery.
Why?
Sir, if there is a celiac artery block or atherosclerosis, then there will be a collateral supplying from gastroduodenal artery to hepatic artery. And if there is celiac block and we'll cut gastroduodenal artery, then there might be liver necrosis.
I'm telling you the point. Around 15 to 20% of the common hepatic artery arises from the superior mesenteric artery.
Okay.
So you have to double check the gastroduodenal artery, whether it is arising from the superior mesenteric artery or celiac plexus. Celiac axis, before ligating the gastroduodenal artery. That is one important point. Have you ever seen a surgery of Whipple's, or you are speaking about your theoretical knowledge?
No, sir, I have seen surgery.
You have seen surgery. What is PPPD?
Percutaneous transhepatic biliary drainage.
PPPD. What is PPPD? Pylorus preserving pancreaticoduodenectomy.
Yes.
So we have not seen pylorus preserving Whipple's procedure, but in pylorus preserving, we 2 centimeter distal to pylorus, we cut the duodenum.
Any advantage on
PPPD
this?
was introduced by Treviso Langmuir during. Yes. 2 points.
Sir, your audio is little disturbed, sir. Karunakaran, sir.
Sir, Jailal, sorry.
Yeah.
No, what is the advantage?
Is there any advantage of PPPD?
Sir, there will be less bile reflux, and normal anatomy is somewhat maintained by preserving pylorus.
What are the recent concepts?
We were thinking in due course.
Sorry, sir.
Your audio is weak,
Please, sir. Please, sir, go ahead, sir. Please go ahead, sir.
Sir, Gujar, sir, you have started asking something. You can.
What are the recent concept regarding this? Akshay? Is audio problem?
Sir, Gujar, sir, you are audible. You can speak, sir.
What are recent concept regarding this?
Pylorus preserving surgery, sir, there is no benefit.
Why?
Will there be any difference in the pancreatic anastomosis if you have done a pylorus preserving Whipple's resection? Akshay?
Sir, I don't know, sir.
I don't know, sir.
Okay. If you have done a pyloric preservation, you can plan for pancreaticogastrostomy rather than pancreaticojejunostomy, because you have a pylorus down. So anastomose that the transected pancreas into the pylorus. People who practice pylorus preserving may try with pancreaticogastrostomy than pancreaticojejunostomy. It has got its own advantages, disadvantages. Like one point you have mentioned, Akshay, your name Sanket, no?
Yes, sir. Saket, sir.
Yeah, you mentioned that you are maintaining the anatomy. Yeah, yes. Reflux is less and maintaining that. That is the points in favor of pylorus preserving. You are maintaining the anatomy and less complication reflux with a stomach stump.
Stomal ulcer can occur, sir.
Any deadly complication after a stomal ulcers?
So persistent hematemesis and melena can occur, sir.
Why hematemesis? Why they should bleed?
Melena.
No. Once they bleed, they will melena. That's all manageable. So devastating, very complication with the biliary, especially the bile is coming again and again.
Chronic complication, long-term complication of any biliary reflux into the stomach. More so a stump, gastric stump, where you have done surgery in the past on the stomach.
Stricture.
No, that is a benign condition. That will be always something long-standing, more dangerous complication.
So
it's a carcinoma again.
So bile reflux will cause metaplasia in stomach wall mucosa, which
And
will
developing cancer, gastric cancer.
Yes,
Gastric
yes, sir.
cancer.
Yes.
Stump
Sir,
carcinoma.
Kanagavel sir, we are done with this.
Sir, I'm just waiting for them all to finish. We are already beyond 10 o'clock.
Yes,
The
sir.
only
Yes, sir.
thing is, we should also give the students to give a chance to ask questions or any doubts to be clarified.
Yes, sir. Yes, sir.
Saket and Akshay, do you have something to ask?
I have one question, sir. In palpation of gallbladder, sir, you told we can move it transversely, but sir, how can we move it? Like we can palpate, then how can we move it transversely?
Moving means not from shifting to one point to B point. It is a transverse mobility of the gallbladder, fundus of the gallbladder. Can be done.
Any other questions, Dr. Akshay and Saket?
No, sir.
But I want to ask Akshay, right from the beginning, and how was your journey? When really you thought that it is a malignancy or benign in the beginning and changed in between? Or there is a lot of twist in this drama? Or what was that?
No, sir. We initially the history and the examination not manipulated, sir. We were thinking of malignancy only. That is the reason why even after we went for CCT of the pelvis rather than MRCP, and then after CCT of the pelvis we had our doubts, so we went for ERCP, first side view scopy, and if there was any mass, then we talked over the phone to gastroenterologist to stent the patient as well and take biopsy outside.
Good. I think it is.
Yes, sir.
I think both the candidates, very well you are presented, and your points were presented in a very, very confident way. You are not confused, and you are very, very systematically working. Only thing, the clinical examination, little more care you have to give. Theoretical and explaining things, you have done very well.
Yes, sorry.
Thank you.
Thank you.
Thank you, faculty. Thank you, Karnakaran sir, Jailal sir.
Yes,
And others, I think both Dr. Rajgopal and Ajay Khanna sir excuse themselves citing other commitments. So I thank Purushantapa sir. In fact, 2 days before only I called both of them and they were kind enough to agree to be part of us. And as a request to both the faculty here, we request your PGs to be permitted to present a case in the coming month or so whenever they are possible available. Sir. So we look forward for yet another PG clinics in the coming Friday. Akshay and Saket, thank you for joining us this evening. I thank Professor Pankaj Modi sir for permitting you, as well as Dr. Ashish from KM Hospital, Mumbai. Shilpa ma'am for permitting them to be part of us here. And we look forward for next PG clinics. Thank you very much. With the permission of the faculty, we call this session a close. Good night, everybody.
Good night. Thank you, Mr. Rishabh.